streaming live. So please join us there. And again, this is a monthly series. So we'll be back in January with Harvard professor Eve Valeria to look at violence and the quarantine. And then back in February with Dr. Reyes of the Phoenix VA to look at the vaccine, the COVID-19 vaccine. So without further ado, I'm going to turn it over to Dr. Alina Fong, and then we're going to hear her wonderful presentation, which is 45 minutes. Thank you so much.
Thank you, Carrie. Thank you, everyone, for being in attendance and being a part of this presentation. This is a joint presentation with my colleague, Dr. Lowen, and we have just been inundated with phone calls from people who have survived COVID-19 and have wanted some help and some treatment for some of these long hauler symptoms. And so we felt that it was necessary to educate people on what we're seeing in clinic and what we know as far as the research bears out is happening with the body with COVID-19. And it affects so many systems that we'll go into. Just to note, we have seen some patients with COVID-19, and we are actually going to do a case study and go over a case study which highlights what these patients struggle with, how they come to us, what we do for them, but also what we can't do for them and what additionally needs to be done. So again, thank you so much for your attention in advance. And Dr. Lowen and I should be around after to answer some questions.
Great, Kristen's gonna start the video, go ahead.
I'm a clinical neuropsychologist at Cognitive FX, and it is my honor to talk to you today about the cognitive and social effects of COVID-19 on caregivers and survivors. For today's presentation, my goal is to cover these following topics, including COVID-19 infection pathophysiology, discussing direct and indirect effects of the virus, discussing acute and chronic symptoms, and also the neurological implications of the infection. I would also like to go over whether or not we categorize COVID-19 as an acquired brain injury. I would like to present a case study of a COVID-19 patient that came through our clinic with chronic symptoms. Implications of dysregulated brain function after COVID infection, and ask the question if whether TBI survivors are more at risk for COVID-19 infection or symptoms, and what we as clinicians, caregivers, and survivors should know for the future. COVID-19 is unique in its ability to affect multiple systems in the body via either direct infection or mechanisms or indirect mechanisms like reduced oxygen or increased inflammation. In this figure by Wu et al. From this year, we can see, for example, on the left, how direct infection can cause injury to vascular systems and lead to issues with increased interleukins and damage to the blood-brain barrier, which is supposed to keep our brain protected from invasion, like from things like viruses and bacteria. Given that COVID can also cause direct neuronal injury and demyelination, this is extremely important. Paniz and Mondolfi et al. April 2020 also showed evidence indicating the neuroinvasive nature of the virus and the likely routes of transmission to the central nervous system. There is conflict currently as to which aspects of COVID pathophysiology may be more important. Some researchers and clinicians are more focused on the potential overreaction of the human immune system, whereas others may be more focused on the oxygen uptake and distribution. Thankfully, I'm not here to enter into that debate. Rather, I want to discuss an organ that can be harmed by each of these pathways, which is the brain. Let's take a deeper look into the direct pathway. A group of researchers indicated that a particular cell receptor, angiotensin converting enzyme 2, ACE2, is likely the cell receptor of the COVID-19 virus, which is also the receptor of the SARS-CoV and HCoV NL63. ACE2 receptor is highly expressed in various body organs. This current study from Karaji et al. 2020 highlights its expression in the nasal and oral mucosa, especially the tongue. These organs could be potentially high risk for COVID-19 infection. This study explored 2 public genome databases and performed single-cell transcriptomic analysis to examine and validate the expression of the ACE2 receptor on oral mucosal tissues, the tongue more than buccal and gingival tissues, and on epithelial cells and lymphocytes. Because high expression of the ACE2 receptor was also found in the colon, consistent with other reports of GI involvement in COVID-19 infection, a fecal oral route of transmission may also be possible, in addition to the oral and respiratory. Furthermore, the reported altered sense of smell or anosmia and taste, dysgeusia, in patients infected with COVID-19 may be explained by the presence of the ACE2 receptor on tongue and nasal epithelial cells that might help mediate neurotropic or neurovirulent mechanisms to modulate taste and smell pathways. Because COVID-19 may be more easily detected in saliva than swabs from the nasal pharynx, the oral cavity is a critical site for the study and prevention of COVID-19. The ACE2 receptor is one target being explored for therapeutics. Now let's look at the indirect pathway. Hypoxia. When a virus replicates and proliferates in the lungs, it causes inflammation and issues with gas exchange, causing hypoxia in the central nervous system, which then increases the anaerobic metabolism in brain cells, including cellular and interstitial fluid buildup, which can obstruct cerebral blood flow, as well as ischemia and vasodilation in cerebral circulation. ACE2 hypertension and coagulopathy. So ACE2 is known to be a cardiocerebral vascular protection factor, playing a major role in regulating blood pressure. So by binding to ACE2, the previously mentioned viruses may cause abnormally elevated blood pressure and possibly increase the risk of cerebral hemorrhage and ischemic stroke. Next is immune-mediated neurologic injury. The immune response can also play a role. Some patients with COVID-19 have died from hyperinflammatory syndrome or a cytokine storm and subsequent multi-organ failure. Coronaviruses have the ability to infect macrophages and glial cells. Experimental models have shown that glial cells are capable of secreting pro-inflammatory factors such as interleukin 6, 12, 15, and tumor necrosis factor alpha after coronavirus infection. And then lastly, looking at the chronic phase, there is possible chronic existence of viruses and may facilitate exacerbation of neurologic damage. Note that neuronal degeneration has been identified in SARS-CoV infective patients, and viral particles were identified in human brain tissue and CSF, cerebrospinal fluid, in MS patients. As an update to this slide, on November 11th, a recent JAMA article came out stating that COVID-19 is not characterized by a cytokine storm, and this is with Cox et al. Again, this research is so new, we need to be aware that the science behind these etiologic pathways may change even in another few months' time. So, a vaccine for COVID-19, what we know and what we don't. So on November 9th, Pfizer reported that their vaccine was in phase 3 and was found to be 90% effective in COVID cases. It is a mRNA vaccine which is injected into the muscle, and this triggers a production of the spike in protein and the antibodies that are specific to the coronavirus. What we don't know, though, is what the effects this vaccine has on the mild cases, the moderate, and the severe, how it affects spread and transmission, how it affects different age groups, and the length of the effectiveness is also unknown. But needless to say, there was a huge spike in Pfizer stock reported on November 9th. Taking a direct quote from Aboud et al. From this year, quote, currently there's convincing evidence that SARS-CoV-2, the etiologic agent of COVID-19, can affect the nervous system with damage and neurologic alterations. These neurologic disorders are grouped into several categories, ranging from non-specific and moderate symptoms such as headache, myalgia, and hyposmia, to severe symptoms including cerebral vascular disease and intracranial infections, end quote. So directly or indirectly, COVID-19 infection can induce or worsen an acquired brain injury. So as we see here, SARS impacts neural function and supply of blood to oxygen and tissue. So what can we learn from other types of acquired brain injury, and how do we utilize this knowledge to maximize potential recovery for these patients? For additional information or conversation about some of these indirect and direct viral mechanisms of COVID and how it relates to brain injury, my colleague and I actually wrote an article earlier this year. We encourage anyone interested to be able to read that. It was entitled Encephalitis and Cytokines, when viruses like COVID-19 have long-term effects on the brain. We discuss how viral infections can affect the brain even when they're not capable of crossing the blood-brain barrier. We talk about how COVID-19 could cause long-lasting brain dysfunction, and whether PCS patients or post-concussion symptom patients should be considered high risk. There's a call to action about how to be proactive about COVID-19 and what to do if you don't feel like yourself after experiencing the infection yourself. Now let's look at organ damage from COVID-19 infection. COVID has known effects on multiple organ systems, which is likely why it's the cause for its wide range of symptoms. Some symptoms affected include the heart. So imaging tests taken months after recovery from COVID-19 have shown lasting damage to the heart muscle, even in people who experienced or reported experiencing only mild COVID-19 symptoms. This may also increase the risk of heart failure or other heart complications in the future. Next is the lungs. The type of pneumonia often associated with COVID-19 can cause long-standing damage to the alveoli, or the tiny air sacs in the lungs. The resulting scar tissue can lead to long-term breathing problems. Liver. Individuals on medications, such as survivors of traumatic brain injury, may be more at risk as their liver is put under even more strain to process medications. The gut is also an area that we're looking into a bit more with these correlative gastrointestinal issues. And for me, importantly, is the brain. Even in young patients, COVID-19 can cause strokes, seizures, Guillain-Barré syndrome, which is a condition that causes temporary paralysis. And it's also linked to increased risk of developing Parkinson's disease and Alzheimer's disease. Many of you may be well acquainted with the acute symptoms during infection, such as fever, chills, cough, shortness of breath, fatigue, headache, new loss of taste or smell, sore throat, nausea, vomiting, diarrhea. In fact, many of us probably have to fill out these questionnaires on a weekly basis at our places of employment. But how many of you are aware that some people may experience lingering issues weeks to months after they are declared even fully healthy? These chronic symptoms are still being monitored as we gather data on COVID survivors, but the question remains, why do certain individuals, or long haulers as they like to refer to themselves as, experience these chronic issues? And why does so much evidence point to the involvement of brain function? If we look to the right, we can see some of these chronic symptoms that these long haulers are experiencing, including COVID fog, very similar to this brain fog that a lot of our concussion patients report. There's, of course, cough, the headache, the dizziness, but then there's also now mood disorders, muscle weakness and nerve damage, and joint pain. As many as 1 in 3 patients recovering from COVID-19 could experience neurological or psychological after effects of their infections. And when we consider the psychological, we must consider the impact of COVID-19 in our current medical field. There's less ability to see our doctor and discuss general and mental health, and there's increased amounts of stress. As we will discuss later, this is a biopsychosocial issue and not just a biological one. These challenges that these long haulers present with also affect clinicians and researchers. So several of these issues are listed here. So there's a lack of criteria. So when is someone considered a long hauler? Lambert et al. Is attempting to compile information about these long haulers because little is known about them. This is a survey prompt posted in Survivor Corps group page. You can see in black here. And it's an urgent poll just asking anyone with these symptoms to provide information. There's a lack of research. How many long haulers are there? As of July, the CDC reported that 35% of symptomatic adults who had tested positive for COVID-19 said that they had not returned to their usual state of health 2 to 3 weeks after their tests. What is that number like now in November? There's a lack of support. So what to do if doctors are unwilling to consider COVID as a cause for their symptoms and or even refer patients for further testing? Often this is not the fault of the clinician or physician, but they may be guided by insurance issues and policy issues. And then also lack of direction. What if the testing doesn't pan out? There are many unanswered questions as the science is so new. An additional complication is that the CDC report of long hauler symptoms appear to be very different from the symptoms that the long haulers report themselves. While the impact of COVID-19 on the lungs and the vascular system have received some media and a lot of medical attention, the results of this particular survey suggest that brain, whole body, eye, and even skin symptoms are also frequent occurring health problems for people recovering from COVID-19. The Survivor Corps group study frequently reported reaching out to primary care doctors for help managing lesser known and more painful symptoms, but that some of their physicians were unable or unwilling to help patients manage these due to a lack of research about these other more lesser known symptoms. A reported 26.5% of symptoms experienced by long haulers are described as painful by these group members in the Survivor Corps. Let's discuss a bit about the neurological effects of COVID. Multiple studies, from single case studies to larger nationwide research studies, have now shown that COVID has significant neurological implications. Some suggest the current estimation of people infected with COVID who display symptoms is far too low, and those with even mild symptoms or even maybe asymptomatic may not avoid neurological complications in the future. In figure 1 on the right, this is taken from Lal et al. 2020, and this displays how the location may have different symptom manifestations. So for example, central nervous system is more correlated with headaches, dizziness, cerebrovascular disease, epilepsy, encephalopathy, and ataxia, whereas the peripheral nervous system is more associated with the loss of taste, hypogeusia, the hyposmia or loss of smell, and neuralgia. Additionally, some doctors have seen evidence of a sympathetic storm in some patients, which is a hyperreaction of the sympathetic nervous system that can cause these seizure-like symptoms and is most common after a TBI. Plant et al. In 2020 further investigated acute neurological and psychiatric complications of COVID-19. Altered mental status was one of the most common presentations, comprising encephalopathy or encephalitis and primary psychiatric diagnosis, often occurring in these younger patients. So what do we know? We know that COVID can affect the brain and it can cause symptoms that mimic brain injury. But what is the cause And how can we detect the cause in patients that show no structural brain or nervous system issues? Well, this is not a new problem. For those of us in the concussion world, mild TBI or concussions are injuries that are also considered invisible on CT and MRI. However, with advanced neuroimaging like diffusion tensor imaging, fMRI, arterial spin labeling, SPECT, etc., we are able to detect dysfunction in spite of normal, quote unquote, normal structural brain imaging. My research is in fMRI, and we and my colleagues here have published articles showing that neurovascular coupling dysfunction is involved in a number of cognitive and neurological disorders, from neurovascular dementia, epilepsy, migraine, brain toxicity, etc. So briefly, neurovascular coupling is the process by which our vasculature provides accurate, precise, and plentiful blood flow to our neurons during activation. NVC, or neurovascular coupling, provides a rapid and sustained source of oxygen and other energy metabolites for our neurometabolic needs. Injury to neural tissues can decouple or uncouple this process, sometimes for months to years. When decoupled, the regional energy supply does not equal the energy demand. So this leads to neurometabolic imbalance and inability to provide substrates for healing, which can lead to chronic symptoms. At our clinic in Provo, Utah, we utilize task-based fMRI. We have adapted 6 different neuropsychological tests to the MRI machine, and each patient undergoes all 6 of these tests, which include a matrix, a reasoning test, trails A and B, a picture naming test, verbal fluency, memory, and a face recognition or visual memory task. We then analyze over 60 different regions of the brain and can provide sensitive and specific regional data, as well as an overall severity index score. But fMRI isn't just useful for detecting brain injury and functional changes in concussion, but also these other injuries like more severe and moderate traumatic brain injuries, stroke, tumors, hypoxia and ischemia, infection, encephalitis, meningitis, and even chemical pharmacological issues. More importantly, from a clinical standpoint, it can be used for targeted multimodal treatment. So our results show that an fMRI targeted treatment approach can drastically reduce chronic symptoms resulting from brain injury. So in this figure, the bar graph on the left is displaying an overall SIS, or symptom index score, severity index score of 3.29. The higher the score, the more neurovascular decoupling or dysregulation is seen on fMRI for that patient. The SIS score on the right shows a 2.8, which indicates normal neurovascular coupling functioning for a control. So keep in mind, this SIS, or severity index score, is an overall aggregate score, which we use clinically to quickly assess the severity of neurovascular coupling or decoupling in a patient, but it does not specify regions of the brain that may be affected. It's like looking at an overall GPA versus knowing exactly what grade you got in OChem. To use the same analogy, both a GPA and an official transcript from your university would give you a fuller picture of your academic performance. To further break down the SIS score, we have published a paper in 2018 on these fMRI biomarkers, which is more or less our transcript that comprise or make up that overall SIS score. These biomarkers are what allow for specific regions of the brain to be analyzed and allows for tailored treatment for our TBI patients. So we had to ask the question, what would we see in a COVID patient on fMRI? I want to discuss now our case study. We were lucky enough to have the opportunity to meet, interview, scan, and treat the following patient. As background, prior to COVID, he was reportedly healthy, active, high functioning. He, I believe, was an actuary and only had one isolated incident in his teens that might have been a concussion, but with no reported lingering issues or symptoms. Based on his PCSS, or his post-concussion symptom scale at intake, despite no other diagnosis in COVID, he reported the following symptoms, and you can read those in the slide. And for those of us in the business, these are very commonly reported symptoms for PCS and other types of brain injury. But, of course, this wasn't your typical concussion. This wasn't a concussion or your typical brain injury. And so upon other questioning that looked at other symptoms, this is what he reported. Now, again, he contracted COVID-19 in February and suffered in the acute phases of the disease from February to March. His chronic symptoms specific to COVID were whole body weakness and fatigue. He reported also having low energy and crashes after overexertion, and he felt like he was struggling to stay conscious. He had muscle tremors, not painful, but they happened all over his body and would flare up with stress. His brain would feel inflamed. He said that his brain felt swollen, like his brain was sunburned. Sometimes he felt pressure in his head if one spot is swollen. He had chest pain on his left side. In fact, he reported going to the ER, quote unquote, a lot at the beginning, end quote, because of this pain. And it was exacerbated by overstimulation and fatigue. He reported dysregulation of his heart rate, like when he's exercising, it should be rising, but it won't speed up. While on the other hand, sometimes he would be resting after moderate exercise and then his heart rate would jump up. And then, of course, anxiety. He also reported electric zaps throughout his body that would come and go, body pain that moved around for the first 2 months after his illness. And it would be anywhere from his forearms, arms, to his calves, to his feet. He also reported temperature dysregulation in his legs and feet. He would see flashes of light. He had photophobia and phonophobia and sensitivities with temperature. He had sensitivities prior to COVID, but it manifests more physically with panic now. After COVID, he developed heartburn and esophageal spasms. He had to be more careful about what he eats and when he eats. In the acute phase, he lost about 2 to 3 pounds. However, in his more chronic phase, by the time he came to us, he had been consistently losing weight, about 1 to 2 pounds a week in April. He even tried to up his caloric intake to about 4,000 calories a day, which slowed the weight loss, but nothing seems to stop it, still only slowing it. And currently, he's dropped from 153 pounds pre-COVID to 130 now. No findings on structural MRI, which were done June and August of this past year. So we were very curious, what would his fMRI results reveal? Because he reported so many symptoms that were very similar to our TBI patients, but also many symptoms that were not associated with typical TBIs, we were very curious as to what his fMRI would reveal. So here we show the patient's pre-treatment SIS score, as I spoke before. The patient's SIS score was 1.89. Just for some context, the mean severity score for the healthy population is 0. The mean severity score for a concussion patient is 2.0. So we can see that his fMRI showed significant dysregulation in subcortical, language, and attentional systems as far as the biomarkers were concerned. On this slide, we take that patient's SIS score, and I'm showing you one of the 6 tasks that actually contributed to that aggregate score. So this figure on the left shows one of the 6 tasks that the patient completes while in the fMRI. Very briefly, the black lines in the graph indicate how much blood is being metabolized by these different regions that we are measuring. Any activation in the dark blue areas or the dark purple areas are within normal limits. Any above that area in the light blue or the white indicated hyperactivation. Anything below is considered hypoactivation. As you can see here, this patient has significant hypoactivation in the posterior medial frontal cortex, inferior frontal gyrus, and the superior colliculus. This indicates difficulties with sensory motor integration, multitasking, impulse control, eye tracking, visual search, visual processing, memory, and language. Based on these findings, we were able to craft an individualized treatment program for this patient. He participated in cyclical, sustained, and targeted therapies, including, but not limited to, neurooccupational therapy, sensory motor training, neuromuscular therapy, physical therapy, neurocognitive therapy, mindfulness and psychotherapy, Dynavision, neurosensory integration, vision therapy, vestibular therapy, along with built-in relaxation and destimulation. This is founded upon our theory of PAR, which we also published in 2018. PAR stands for Prepare, Activate, and Recover, where preparation includes cardiovascular expenditure, exertion, aerobic exercise. We then activate the brain with cognitive therapies, and we have to build in rests and destimulation. Much of our theory on active therapy is built upon the works of my colleagues John Letty and Barry Willer over in Buffalo, and we definitely subscribe to a very active route towards healing. This slide presents the patient's actual week-long schedule. These are all 1 hour long therapies with one-on-one treatment, Monday through Friday. He underwent fMRI imaging on Monday with therapies beginning that day. And then on day 2, 3, 4, therapies were from 9 to 5, basically every hour, culminating in another fMRI scan and some treatment again on day 5, which was Friday. This was very intensive treatment, very frequent treatment. We crammed about 6 months of therapy into 1 week with this patient. We have the same program for our concussion patients as well, and we see very encouraging results. Now, when comparing his pre and post fMRI, we did find that this multimodal therapy significantly improved his neurovascular coupling dynamics and some of his symptoms. He went from a 1.89 pre-treatment to a 0.14. The patient was still reporting symptoms despite drastic improvements with neurovascular coupling, which led us to the question, why? This was very concerning to our team because when compared to our typical concussion patient, a typical concussion patient can see a 75% reduction in symptoms, both subjectively and objectively with fMRI imaging. And we know that neurovascular directed therapy works. We have seen benefits of targeted autonomic nervous system therapy, vestibular, visual, and other therapies. So why was this patient different? Well, first of all, he wasn't a concussion patient, right? Even though he had many of the symptoms of concussion patients, he also had a number of symptoms that were outside of what we thought were similar to concussion patients. Even after treatment, he still met language and attentional biomarkers and demonstrated dysfunction in a number of memory systems. So many of our other concussion patients overcome these within weeks. However, this person's breathing, vestibular, and overall physical indices were still alarming. We last checked in with this patient on September 15th, and he reported that weight loss is still a huge concern. We have kept in regular contact with this patient, and we referred him to a pulmonologist, a gastroenterologist, an endocrinologist, and we continue to monitor and work with this patient with, of course, the goal of hopefully 100% symptom remediation. So the conclusion is neurovascular coupling is a key part of the puzzle, but we are still missing some of these pieces. So in summary, COVID-19 can induce changes in brain function that can persist for months even after the virus is cleared. The cause of COVID-acquired brain injury is multifold, including hypoxic and inflammatory damage. And dysregulated neurovascular coupling after COVID-19 can be treated, but other issues may hide improvement in neurovascular coupling. So what does this mean for TBI survivors and caregivers in terms of prevention and management? How do we treat COVID-induced ABI? In order to understand how to treat COVID-19 as a whole, we must first look at the psychosocial effects of COVID-19. Dubey et al. Quotes, "Disease itself multiplied by forced quarantine to combat COVID-19 applied by nationwide lockdowns can produce acute panic, anxiety, obsessive behaviors, hoarding, paranoia, depression, post-traumatic disorder in the long run." Dubey goes on to state that adverse psychosomatic outcomes are nevertheless expected to increase significantly due to the pandemic itself, and also due to constant flow of readily available information and misinformation and reinforced messaging obtained via online social networking services of almost all forms. These psychological effects have been fueled by an infodemic spread via different platforms on social media. Consideration for involvement of effects such as irritability, fear of contracting and spreading infection to family members, anger, confusion, frustration, loneliness, denial, anxiety, depression, insomnia, despair, and fear to extreme consequences, including suicide, must be considered. But I believe there are ways to combat this. The COVID-19 pandemic and quarantine have created challenges for people all across the world. This is perhaps especially true for our TBI survivors and their caregivers who are already dealing with the physical, mental, and emotional consequences of brain injury. While some TBI survivors may initially find following COVID-19 restrictions not so different from their daily lives, the increased effects on psychological health, relationships with family and friends, and lifestyle patterns can have noticeable long-term consequences. We were able to publish an article in the United States Brain Injury Alliance summer newsletter about tips for the summer of COVID with a brain injury and beyond. In this article, we addressed some of the biggest issues COVID-19 and the quarantine may be causing TBI survivors and give you tips on how to manage these issues. They centered around mostly mental, physical, and lifestyle strategies. In the mental area, we espoused and encouraged meditation, mindfulness, even journaling with a gratitude journal. Physically, we encourage people to get outdoors more safely, of course, and socially distanced, in a socially distanced way, maintaining good exercise and regular exercise, yoga, stretching, things like taking a bath, and maybe even trying PMR or progressive muscle relaxation. And in the lifestyle category, implementing proper sleep hygiene, educating yourself on what sleep hygiene is, maintaining a healthy diet and nutrition, and very importantly, keeping up social connections, either with phone calls or video calls, writing letters, meeting up in a park, maintaining social distance. But these are just some very practical ways that we need to engage in order to stay healthy, mentally, physically, and socially. In our experience with brain injury, there is a spectrum of issues, from brain dysfunction to PTSD-like symptoms, from either the event or years of trauma from dealing with undiagnosed, untreated, or misunderstood symptoms. We also see patients with all or some of the issues in the following areas shown here in this figure, including genetics, brain dysfunction, neurovascular dysfunction, hormones, visual vestibular issues, issues with your autonomic nervous system, psychological issues, and nutrition. Every patient is different and will need an individualized, multimodal approach. COVID-19 as a type of acquired brain injury should not be ignored by brain injury survivors, caregivers, or clinicians. While we do not yet have evidence that clearly shows ABI and TBI survivors are more at risk, the implications are clearly there. So to answer the question, are brain injury survivors more at risk for COVID-19 infection? I think that my answer would be yes. COVID-19 and hormones. We already know that TBI survivors are more at risk for hormonal disruption. Different endocrine glands or organs that can be affected by COVID-19 include the pituitary. There's possible hypothalamic pituitary dysfunction and alterations in antidiuretic hormone metabolism. Next is thyroid. Sick euthyroid syndrome is a possibility. Adrenal. There's probability of higher susceptibility to COVID-19 in adrenal insufficiency and possibly Cushing's syndrome. Bone. Low vitamin D may be linked to more severe disease and increased risk of hypocalcemia. Testicles. Higher susceptibility and worse outcomes have been reported in men. Diabetes. Worse outcomes in diabetic patients. And then also obesity. There's a worse prognosis in obese patients. Brain injury survivors and caregivers are more at risk for psychological diagnosis. So I want to talk about the psychological impact of symptoms of brain injury on COVID-19. 1 in 5 individuals may experience mental health symptoms up to 6 months after concussion. And this is from the TRACK TBI study. Post-intensive care syndrome for the family, or PICS-F, is the constellation of depression, anxiety, post-traumatic stress symptoms, and complicated grief that can occur in family members of patients that have been in intensive care units. Also, both the central nervous system and the autonomic nervous system are likely involved. Our patients with coincident diagnoses of anxiety and or depression experience significantly higher symptom load despite similar rates of neurovascular coupling improvement. So brain injury survivors and caregivers are both more at risk for psychological effects of COVID. As complicated as COVID is for clinicians, we put together sort of a master checklist for us when treating these COVID patients and these long haulers. These are just some areas that we did not want to miss when we're doing a comprehensive evaluation for these patients. And interestingly, issues with one system can absolutely cause issues with another, like, for example, interactions between neurovascular coupling, visual, vestibular systems, and also dizziness, vertigo, etc. And so we always consider the psychological side. There needs to be evaluation and support for the mental health aspect, cognitive behavioral therapy, family counseling, especially because COVID is also associated with quarantining and isolation. And so the psychological side almost needs to take precedence, which is why we listed it at the top. Hormone evaluation, so blood, urine, other testing of adrenal, gonadal, thyroid, pituitary, and hypothalamic function also needs to be a part of this comprehensive testing. Gastrointestinal, looking at IBS, leaky gut, microbiome, food intolerance, absorbance, and motility is important. Pulmonary issues, of course, O2 and CO2 balance, diaphragm dynamics, the possible lung scarring and inflammation that can persist. Now, of course, the ANS, the autonomic nervous system. We have to look at heart rate variability, vagal nerve function, and hypotension and hypertension, and other dysautonomia. And then, of course, neurovascular coupling, functional MRI of subcortical areas, attentional, visual networks, language, executive functioning systems, and then targeted cognitive and physical rehab of this neurovascular coupling. In conclusion, where do we go from here? And what is the future of COVID-19 management for the brain injury community? In summary, we provided evidence that COVID-19 should be considered an acquired brain injury. We talked about advanced neuroimaging and aiding in diagnosis and treatment. And we talked about ways to combat these neurological, psychological, and social factors and issues associated with COVID-19. But the most important thing that I want to end with is hope. If you search the term COVID-19 on clinicaltrials.gov, there are now, as of today, which is November 12th, 2020, over 3,800, almost 3,900 publications of clinical trials, which included studies ranging from evaluation of small molecule pharmacotherapies, mesenchymal stem cells, or T-cell-based therapies, convalescent plasma therapies, immunoglobulins to medical devices in the treatment of COVID-19. And that's an excerpt from Gupta et al. 2020. So much research is being done, with so much more research to be done. I would like to thank you so much for your time and attention today, and I hope I have shed some light on this subject for all audiences, I know, including clinicians, researchers, survivors, and caregivers who are listening. I know that with the rapid rate of research surrounding COVID, this information may be outdated in a few months, and I look forward to the opportunity to speak again on this subject. And thank you again for your attention, and have a great day.
Thank you to Dr. Fong and Dr. Lowen. This is a new frontier for all of us, in addition to the rise in addiction issues, anxiety, and depression that COVID-19 has brought, and the financial instability and the prolonged stress of the year that we've been living in. Those of us who work with survivors of brain injury, we have all of our usual cases. People are still falling, there are still car accidents, and now we have new survivors of brain injury due to COVID, in addition to sometimes long-term survivors of brain injury who had lived independently, done just wonderfully in the community, are now destabilized in housing or in other issues due to COVID. So there will be a follow-up email with the Facebook recording. Please refer to that if you'd like to see a recording of this event and absorb it again. We also will have a brain injury chart for TBI versus non-traumatic brain injury that will talk to you about all types of acquired brain injury. So please remember, not every acquired brain injury that happens after birth is a TBI. There will also be a recording that Dr. Fong did for us on the keto diet and post-concussive headaches. And I have to tell you, at the Brain Injury Alliance of Arizona and throughout the country, one of the most increased call we've had is around migraines. These are just stressful times. So that's a very interesting video recording as well. And that was Dr. Fong and her colleagues were going to actually come to Arizona and present that in person. So we're grateful that with everything that went on with COVID that she could record that. We'll also have 2 blogs that this presentation referred to on the summer of COVID, and also what to do if you have those COVID and those symptoms persist, the neurofatigue, the dizziness. What do you do? So we'll include that blog, which was written by Dr. Lowen. And spoiler alert, sometimes a call to your Brain Injury Alliance chapter is a great place to start. And just a reminder that at Brain Injury Alliance of Arizona and throughout the country, we are open, we are seeing clients, everything just went virtual, and we're still here to serve you. So Dr. Fong and Dr. Lowen, we have a few minutes. We'd love to hear additional thoughts from you and any questions.
Well, I just wanted to just quickly say, thank you so much for bearing through that. When I first gave this presentation, it was for the Brain Injury Professional Conference here. And so I tried to modify it. And so I'm sorry if the beginning is a little science-y, even for me, but it just kind of sets the stage for how complicated and complex COVID is, and how we still don't truly understand all of it. And again, I gave this presentation in October, and we had just adapted it in November, and there was already new data. And I know that, actually, Carrie, I'm not sure if you're involved in this, but Dr. Lowen and I are on a CDC task force for pediatric brain injury. And I actually brought this up, that we're presenting this. And, there's still some question as to whether or not COVID-19 should be considered an acquired brain injury. And when I brought up all these things to that task force, you know, they're like, yep, send this presentation, because I think those of us who know people who've had it and are doing research in it and know what TBI is, we can see that COVID-19 should be considered an acquired brain injury, especially with how many different systems it can affect. So anyway, again, thank you so much for that. And we would be happy to take your questions, and I'll let Dr. Lowen start.
Good. Dr. Lowen, would you like to say a few words, or should I start going with those questions that are in chat?
You know, I think Dr. Fong summed it up beautifully, so let's jump into the questions.
Okay, fantastic. Lynn asks, I was asked to do a vaccine trial, but I have a TBI, so I don't know if I should do it. What is your opinion? And again, we can't give medical advice today, but what is your opinion?
Mm-hmm. Yeah, so right now there are actually two different types of vaccines that are being discussed. One is the more standard, you're injected with a, you know, non-infectious particle, and then your system sees that particle, it breaks it down just like it would with the flu vaccine. Your body goes, this is the bad guy, and you develop an immune reaction to it, keeping you safe from future infections. However, a lot of discussion has gone into the mRNA vaccine, which is a little bit different. All that gives you, it's injected in the same way, you know, into that shoulder muscle, but it simply gives your system the phone number of the bad guy, essentially. It tells your system, these are the pieces you're looking at. Both are extremely safe, but both are being still tested. However, the Pfizer vaccine right now has been approved in the UK, has gone through rigorous testing, and they are already going to implement vaccinations as soon as possible. Now let's talk about risks for survivors of TBI. I'm going to be super honest, there are a lot of different factors. All of us are at risk for side effects of a vaccine, whether it be the very mild of, redness and soreness around the site of injury, to some people developing mild symptoms as a result. I would say with the, depending on the type of severe TBI that you have, if you have any immunodeficiency like issues that may be related to your brain injury or just something that you're dealing with, consider talking to the individuals who have invited you to do the study. What are my risks? What are the possible side effects I will experience? Where do I go to if I develop side effects? But on the whole, these vaccines have been shown to be very safe. They are inducing a natural immune reaction that you would have with any kind of bacteria or virus. So the probability and the possibility of actually being vaccinated successfully and not getting COVID, it might be something very much to consider, getting that vaccine and leading the way for other TBI survivors to get those vaccines.
Fantastic. So many good questions. Johanna would like to know if you can share any of your slides, and if you can, Kristen will include them in the outgoing email. So thank you for that question, Johanna. We are always happy to share when the speaker is able to do so. Next question is from Joffrey. And this is so good because we on a regular day have a lot of issues with sometimes healthcare providers recognizing the invisible injury or the invisible disability of brain injury. And now we're going to have all these additional people with neurological changes entering our healthcare system. So Joffrey would like to kind of hear your thoughts on how do you think the millions of people who will have survived COVID will best approach their healthcare providers in seeking both understanding and rehab support for the cognitive and other changes when this crisis is less of an obstacle?
Mm-hmm. So Alina, I'm going to throw you under the bus slightly because I would like your opinion on this as well. I'm going to start out by saying we are already seeing, unfortunately, some opposition from healthcare providers to seeing patients who these long haulers are already getting pushback. Either their symptoms are not being seen as real, they're being seen as simply related to mental health, they're not being referred to the appropriate providers, which is sometimes absolutely necessary if they're going to bill insurance. So some of these patients may not be able to get to see the right people or may not be able to be paid for seeing the right people. I think it's going to come down to finding an advocate And in many cases, for example, Dr. Fong and I are serving as advocates for these patients. We are calling doctors, we are referring patients. It's finding individuals that do know how to traverse the industry of healthcare. I'm going to be super honest. And in many cases, it may be taking primary research to your doctor. That is one benefit that COVID has had, is that suddenly across the media, there are researchers speaking out about this is real, this is happening. And in many cases, bringing that evidence to a practitioner and going, this is what I'm experiencing, this is real, I need you to do this for me, may start a conversation. Dr. Fong, myself, and the clinic have actually recently done another blog where we came up with a checklist for how to talk to your doctor about hormonal disorders. And a lot of it comes down to bringing someone to that appointment with you that may be able to bring lists of medications, talk about symptoms, having a family member advocate with you, standing your ground. It might take a little bit of a fight, but I think that everyone should know that there's a lot of people on their side, and to not feel alone, to start a conversation. And I'm going to be super honest, if you feel like your doctor's not listening, get another one.
And this is such a hard time too, because I know healthcare professionals who've had the virus themselves, and they're having a hard time distinguishing what is kind of that 2020 blah and what is a lingering symptom.
Mm-hmm. Well, I think that it comes down to, and this is what Dr. Fong and I deal with a lot, is that, it's evidence. It's how much evidence do I have? For example, many members of my family, especially during this holiday season, are dealing with a lot of mental health crises. We're alone, we're missing each other, it's very difficult. But if I have a family member who's saying, I don't know what's wrong with me, I've dealt with mental health before, but now I feel like I can't absorb food properly, I'm losing weight really quickly, my menstrual cycles are all over the place. I'm going, that evidence is stacking towards, you had a COVID infection, and now, everything is lining up to be associated with that. And you can obviously have both. All of us are grieving right now with all of the loss that comes with COVID, but grief and the effects of COVID that Dr. Fong just talked about for these long haulers are simply going to make that individual in more need of help and support.
Can I just add something real quickly? And I know this is really jumping around, but back to that one question about the vaccine trial and having a traumatic brain injury, I just really want to drive the point home that Dr. Lowen said, which is tell the researcher that you have a TBI. That might preclude you from being in the trial, meaning that they won't even allow you to be in the trial right now, or they might, but then they'll document and they'll watch you specifically to see. So please be very upfront with them. So that's the first one. The second one, I think Dr. Lowen said it, perfectly, but I do think that COVID-19 long haulers are going to have the same uphill battle that mild TBI and concussion patients have had to fight for decades. Maybe the fight won't be as long because of, how widespread social media is talking about it, and how much more informed patients are going into their doctors. But the last thing that I think you should do, so this patient that came to us was a part of like a 7,000 person group, right, JC? Like a long hauler group for people across the United States. So, and I don't remember the name of it, but they're out there. But if you can join some type of an online group and throw your questions out to them, there, unfortunately, right now, there aren't very many clinicians like us who see it, we believe it, and we are willing to treat it, So I think part of it is, some doctors don't agree with it. They don't believe it yet. They're not sure what to believe, and then they won't help you get treatment. So join these online groups where other people are fighting the same battle you're fighting, and join together.
I believe it's called the Survivor Corps.
Okay.
So band together, power in numbers. We have a great question. If you've had COVID once, can you get it again?
Yes, it is, so we're having to go off of data right now. We're not talking about reinfection studies. We're talking about very basically looking at large populations. So the reinfection rate is reported at this point. Somebody's had it before and then shows symptoms again, is so far low, but absolutely possible. There are complications, however, in some patients that may have just a long-standing COVID infection. For example, they have the infection, they may, have lowered symptoms, think that they have cleared the infection, but then symptoms come back, but it doesn't mean that they've been reinfected. So it's going to take probably another couple months to a year of studies to determine what the reinfection rate is. We're also dealing with, there are multiple strains of COVID, same as with the flu. So there's a reason we get a yearly flu shot, because it can evolve. So research will be updating, but if you've had it once, don't suddenly take that as, oh, I'm free and clear, I don't have to wash my hands, I don't have to wear a mask. You are still at risk of getting it again and possibly developing long-term sequelae or dying from another infection.
And to add to that too, there is research, talking about antibodies, right? But again, we don't know how long those antibodies last. There is a lot of good evidence suggesting it does last for a period of time, but we do not know exactly how long that is.
And Kristen said, thank you for the advice on how to advocate for your healthcare. It's so vital and important. There's nothing as frustrating as being dismissed when there's something going on. Carmen would like to know, we talked about brain injury, but do you think COVID can be different or affect people differently if they have some other brain issue, like a dementia, a disease process in the brain?
That's a really excellent question. So physiologically, when you're dealing with a neurodegenerative disease, there is going to be loss of brain cells. It is progressive. So it's not something like, for example, mild traumatic brain injury, where there is an acute incident and then sequelae coming from that. That may be persistent, but it doesn't mean that there's going to be constant damage to the neurons. Now, what's very interesting is that some neurodegenerative diseases can make you more prone to direct viral infection. So absolutely, the COVID infection process could be very different in individuals whose neurons are less able to protect themselves. Or the glial cells, the support cells in the brain, who are the neurons' protectors, may be so distracted with trying to keep the neurons healthy, they may not be able to defend against an invading virus. So I don't know of any current research with enough numbers to say what COVID effects on individuals with dementia, mild cognitive impairment, Alzheimer's, Parkinson's might be. However, my thought would be that the likelihood of either extreme, issues coming from the virus or risk of death would be higher in individuals with a neurodegenerative type disorder.
And then to add to that, even stepping away from the biological neurological side, with these patients with dementia, usually, they'll have difficulty with expressing themselves socially. Just communication is difficult. And so even understanding what they're going through, they might not be able to be processing what's happening, if they do have COVID. It could just be, there are other aspects of dementia that I think could make contracting COVID much harder for that patient versus the average patient, the average person.
Okay. We have a question. If you can get COVID a second, third, fourth time, can the symptoms be different each time? Could it get worse each time? Does it build up?
We're getting the most awesome questions. I love these. So I will go from the mild traumatic brain injury stance, which is, yes, they can be different every time. They can be worse every time. The reason being that every insult, we'll call it, every injury, every viral infection, your body may respond differently depending on the season, depending on how much you're eating, depending on what other infections you may have been introduced to. There are so many fluctuating factors in our body, it's going to be new every single time. Now, let's say that, you know, an individual that may respond well to the virus the first time, their immune system may, you know, respond well and adequately to the infection. The second time they might get it, it might be shorter and it might be less intense, but there always is the probability that, who knows, the body may have not recovered from that first infection and the second one may be worse. So absolutely take every infection as a new infection. It's a new beast, it's a new monster. It's going to take new techniques to figure out what's going on and what to do about it.
That's really good information, because we've seen some articles come out about the loss of taste and smell, almost like it's this cute little thing, but that's impacting something in your brain. So what else that maybe isn't that, you know, noticeable is going on?
Actually, I don't want to be one of those people, but the loss of smell and taste is extremely concerning. It actually indicates that there's direct infection of neurons. So that we've got this plate right here in our sinuses. It's called the cribriform plate. And we actually have neurons that stick down from that plate that allow us to sense smell. The fact that we may be having issues with that neuron suggests that COVID infection in olfactory and oral orifices, that virus may be getting to your neurons. Imagine what it can do in your brain.
That's fantastic information. Anna has a question.
Viruses, that's me.
I also want to say thank you to all the people who are here. I know we are in month 7 of Zoomageddon or whatever we're living through. I just really thank you for your response and your engagement. We have people here from all over the spectrum: crisis response, people who are doing trauma-informed work in the community, brain injury alliances and brain injury professionals from all over the country and some international. So I just want to thank you for really caring and engaging in this emerging issue. Anna has a question. Anna Schmidt, I don't know if you're in Arizona. She says she's in behavioral health and she sees clients that appear to have undiagnosed brain injury, all too common, especially in vulnerable populations. Has anyone seen a connection between brain injury and behavioral health? And I'll do my Arizona plug. Anna, yes, we'd love to work with you if you're a local or refer you to someone. There's screening that can be done. Free referrals, and we can help. We also have a vulnerable populations committee in Arizona to address and help people seeking healthcare. And so we're going to have a whole new wave of people who, if they've had problems in the past accessing healthcare because of different things that make them vulnerable in our community, we're going to see those issues play out on a mass scale. So that's my Arizona plug. Dr. Lowen, and do you have any thoughts?
No, in fact, Anna just said she is in Arizona. And so I think that would be the best resource. And to answer your question, Anna, is yes, absolutely. We see this connection more often than we'd like. More awareness is what we need. Just like, so Carrie is the executive director in Arizona for the Brain Injury Alliance there. I'm the vice president, soon to be the president, January 1st, of the Brain Injury Alliance of Utah. But that is our job, is to help someone like you get validated, you know, get medically understood, and get the resources that you need. But you're not alone.
No, and we are having our brain injury conference for the community in Arizona is virtual and free on the 10th. And we are having the OG, the godmother of screening in the criminal justice system, Kim Gorgons, is going to be attending. She works very closely with the Brain Injury Alliance of Colorado. Shout out to them. They've done amazing things for addressing the extreme prevalence of brain injury in the criminal justice system.
Yes.
That is all the questions I see. I really thank you for your time. Any final thoughts or any questions I didn't get to?
No, I just think, stay tuned for, is it next week that Eve is speaking?
In January. So it's a monthly series. In January, Eve is going to be speaking about the uptick in violence that has happened during COVID and the resulting shutdown, lockdown, financial insecurity.
Yeah, and just for those of you who are still on, I mean, this community is very, very small. We all know each other. I love Eve's presentations, and it is going to be, it's very shocking how this quarantine and how these lockdowns have and COVID has affected the the amount of intimate partner violence and domestic violence, and how the legal system, you know, it needs to be more aware of this, the medical community. But yeah, COVID, this is just one aspect of what's happening with COVID, right? Not to mention all of the other TBI that can come from it, from abuse. So yeah, thanks for sharing some time with us, and I hope it was interesting.
Please come back, both of you. We were so excited to be able to host you today, and we look forward to having you in the future. Thank you so much. And I want to say thank you to Kristen at the Brain Injury Alliance office. She's our operations person. She makes sure everything goes smoothly when things go online, from registration to day of. So thank you to Kristen. We could not do it without her.
Thanks, Kristen. Bye, Carrie.
Thank you, everyone.